Good evening. It's exactly 5:05. My topic of discussion today right now is a myocardial contrast echo. Let me show a couple of slides carrying forward the tradition created by Dr. Nanda. Let me show a couple of slides talking of incredible India, especially the people who belongs outside India. And the guys who are from India, they have not seen this kind of a picture, which is true in day-to-day practice. This is one you must not have seen anywhere except in India. You can see, you can count 6 of them riding on a small motorcycle. How often do you treat your kids with an ear illness? Here is a grandma treating a child with putting an oil inside the ear. That's how do we travel in India, even today also. And here is a monkey which is being tied with a chain on a train. Look, nobody pulls these bogies except the human beings, and how we fight with each other. And that's what an acrobat playing with the wheel of a cycle, and that's a true image back from India down south. And this is what down from Punjab, the guy like a Shiva riding on a motorcycle with all kind of a skull in his neck. And that's what the true picture. This is our politician. Burning and playing with the fire. This is often seen when we have a Muslim festivals in our country. And this is how a monkey crosses on top of a road. And that's how animal harmony. Yesterday I was talking to a person. One guy told me what is a harmony between husband and wife. He said wife always says wife and a husband says har money. Har means har and money is money. If a husband maintains harmony, means he has to lose everything including money. That is harmony. That's what the picture when we have a festivals back in West. And that's again another acrobat playing with a cycle. Another one playing with a monkey. And look at this picture especially. This is outside a picture hall. The policeman could not get inside. He is trying to get inside a picture hall. Place to sleep for a monkey. That's the best place. And another one to sleep on a bicycle rickshaw. How to prevent yourself from a rain. That's an image. Person riding on a motorcycle in Ahmedabad. Cool yourself. Not inside, but outside itself. Nag Devta. And this is very common in India. Thanks. Let me get back to my presentation. Well, the topic is again evaluation by myocardial contrast echocardiography. Myocardial contrast echo is possible how and why. This is one picture image from our own lab talking about a myocardial contrast injection into the LV pacification and subsequently perfusion of all the myocardial space. This is possible because of two developments related to echocardiography. One is a harmonic imaging and second is the invention of microbubble which can be intravenously delivered and highly hyperechoic. History dates back to late 60s when we used to use a normal saline for a contrast echocardiography. However, the myocardial contrast echo dates back to 1996, again back to one of the Indians, Sanjeev Kaul, who first published his paper in ACC talking of myocardial contrast echo. And that's what he talked about it in 2011, 2009, talking about the same things. He talks about his experience from earlier days of a training for myocardial contrast in 82 to a present status in 2010. What is myocardial contrast echo is an optimal detection of a contrast in intracardiac cavity, and in the myocardium it requires understanding of backscatter properties of the microbubble and the physics of ultrasound. And these microbubbles, they are nothing but a shell of a denatured albumin, lipid or palmitic acid filled with air, that is for perfluoropropane or perfluorohexane or dihydrosulfide or docodecafluoropentane. Well, many agents are available worldwide. We had 2 of them in India, Sonoview and Definity. Somehow Definity has withdrew from India in last couple of months. Only Sonoview is available as on today. How do we give it? We give it with either with a bolus of 0.2 to 0.5 ml contrast IV followed by saline flush, or we use a continuous infusion of 0.4 ml per kg diluted in 100 ml of a normal saline and continues intravenously. And for evaluation of both of them, I always use a myocardial perfusion, and for wall motion evaluation, a continuous perfusion by using a continuous infusion technology. How does it help in echo evaluations? The best way is it helps in endocardial border detection and enhancement, especially in a population who is obese, have a pulmonary artery disease, and other patients dependent factor leading to inadequate visualization of endocardial borders. It's better interpretation of exercise and stress pharmacological echocardiography, and in clinical trial using contrast improved endocardial definitions. But in our lab, a non-compaction of LV was better identified when we used a myocardial contrast echo. Can you identify this abnormality? Normal? Anybody would like to vouch? Normal? Possibly LED lesion or anything else? Well, this can only be possible once you inject contrast at the same time. Nobody will think of a non-compaction of LV along with LED infarction in this particular territory, but when we injected a contrast, the picture was absolutely clear. Same thing, aneurysm or not an aneurysm. Here appears to be a small aneurysm in an apical septum. And when we injected a contrast, there is absolutely no evidence of an aneurysm in this particular frame. Indication, we use in accurate assessment of LV systolic functions, and especially in suboptimal imaging, and for edge detection, stress echocardiography, as I said, suspected apical defects and apical hypertrophy in some of the cases. Here is an example for 140 kg of a person who came for RV function evaluation, a patient of a chronic obstructive lung disease. Can we look at an RV function and say for definitely whether this RV function is normal or abnormal? And as soon as we injected a contrast for this patient, we can definitely say this RV function is definitely, apex is gone down significantly. What is the gradient in the same patient? The gradient says 39 millimeter of mercury. But once we injected a contrast, the gradient is categorically at least 56 or more millimeter of mercury in this patient of 140 kg of weight. 150 kg of person, we are looking for an LV function. These are images from my own lab, where we do constantly the kind of a contrast echo. And here we can categorically say that apical septum along with apex is definitely hypokinetic in this particular patient. Apical hypokinesis or not? The same patient with the contrast, we can say that possibly apical hypokinesis is present. Post-thrombolytic evaluation. This is a very common scenario, the places where we don't have enough facilities for immediate angiography or angioplasty. This was a guy who had a post-antival MI, was thrombolized in Bhatinda, that is approximately 7 days down the line, that is the 14th or 15th of December 2010, and was asymptomatic now. How do we evaluate these kind of a patient? We can utilize this kind of a patient by looking at this particular pictures, saying that whether the perfusion is maintained in the apical segments or not by using a perfusion technology. I'll come down to that in a couple of seconds. Well, we can look over here. There's some amount of perfusion which is preserved in apical segments in this patient of a post-antival MI. Indication, I showed you evaluation of a tricuspid regurg, aortic stenosis of pulmonic venous flow, that's enhanced Doppler signals, enhanced endocardial bundle delineation, enhanced anatomy or delineated anatomy of thrombus or a fistula, myocardial perfusion, and that possibility in a time to come is a drug delivery and the pressure measurements over a period of time. Indication in clinical practice, obviously coronary artery dissection, myocardial perfusion, infarct-related artery patency, no reflow phenomena, endocardial border enhancements, interventional procedures, especially in HOCM, and evaluation of mass, whether vascular or not a vascular. And I say in gist to say that assessment of a function even at microcirculation or microarterial levels. Presently utilized indication, apart from all this, we put them use in emergency rooms, in stress and pharmacological stress echocardiography, detection of perfusion in infarct-related artery, prognostication of patient after intervention for acute MI, detection of masses, interventional treatment of a HOCM, and what we started utilizing these kind of images, especially in intensive care area, where the patient is lying flat on their back and they have especially a very poor echo windows during evaluations. Detection of a coronary artery disease. Significant role it plays in detection of a coronary artery. With one bolus, we can look at the wall motion abnormality, and the same bolus can help you evaluating how much is the perfusion in apical segments for this kind of a modality. This is the one bolus which first opacifies the LV and subsequently opacify the endocardium. You can concentrate and see it again. It practically makes this endocardium literally brown in color, which is the microbubbles, which are with the blood, which fills up the endocardium. This is one paper which talks of myocardial contrast echo in emergency room. Well, we have a coronary artery disease. In our labs, we do not, in our country, we do not use this modality in emergency room. If somebody walks with a chest pain, do not have a wall motion abnormality, if we inject a contrast, if the perfusion is maintained, obviously majority of time we can say that this person may not have a coronary artery disease. This is one example from a dobutamine stress echo with a myocardial contrast. Look, this is a resting image, this is a low dose, this is a high dose, and this is a peak stress echocardiography. If you happen to look at this particular images, only one segment, this is which is hypokinetic or akinetic, with a low dose as well as with a high dose of a dobutamine echo, and which reverts back to normal. Picking up this small endocardial, this segment, with stress echo is obviously difficult, and when we utilize a myocardial contrast echo, it makes our jobs much simpler than anybody else. Myocardial perfusion, and if I really have to gist this a myocardial perfusion, again an image from our own lab which talking of myocardial perfusion, this LV opacification happens, and once the LV opacification happens, if you spend time, if this segment gets opacified maybe partially or wholly, possibly this microcirculation is preserved in this patient of a post-MI evaluation. This is one slide which is a static slide. I wanted to pick up this slide and show that how does it make a difference for evaluation and prognostic purposes. This is a person who suffered with acute anterior wall MI. We did a myocardial contrast echo. There is no perfusion in apical segments. And this is a later on slide which talks of LV remodeling has happened over a period of time. In contrast to a patient who had anterior wall MI, we did a perfusion study along with LV opacification. The contrast was still present in apical segments. And later on, this is the segments which is being on a static film, showing that his LV has not remodeled. It still remains a bullet-shaped structure. So this is one modality which can tell you the person whom you have done an intervention or the guy who is suffering from a coronary artery disease, whether he is going to become a remodeled LV or a poor LV systolic function over a period of time or not. Many things. Assessment of a reperfusion, another important presentation, like we can detect a myocardial impending rupture with this kind of a paper which was published in cardiovascular ultrasound in 2006. There we were able to detect this kind of myocardial perfusion. This is one schematic diagram published in JACC talking of a use of myocardial contrast echo in acutely reperfused myocardial infarction. The same thing which I said, if the perfusion is maintained, obviously these guys, they're not going to have any further remodeling. Another indication, prognostication with abnormal. One recent presentation talking about contrast echocardiography predict cardiac event patient with suspected acute coronary syndrome but non-diagnostic electrocardiogram and 12-hour troponin test. Talking of the same thing, if perfusion is maintained, obviously they do much better than other thing. Utilization in hypertrophic obstructive cardiomyopathy, we can target the septal branch and then we do an iatrogenic infarction for these kind of patients. We can look at the mass. This is the one image from our own lab talking of a mass whether vascular or non-vascular, and this is the same image we're talking about RV obliteration as well as LV obliteration in a patient who is suffering from endocardial EMF. In future, we are going to have a designer microbubbles talking of thrombolysis or localized thrombolysis depending on a gene therapy, viral genome delivery and determination of vascular instability. Personal experience, done more than 1,000 plus myocardial contrast echo as on today till date, couple of cases for masses, many for evaluation of a gradient and none side effect till date. That's what the people are afraid of. And the second thing like to give a take-home message. The vial of a myocardial contrast echo costs only 3,500 to 4,000 rupees. If we have 8 patients, we can deliver that vial in 8 patients. It comes out to be only 500 rupees per patient, which is not much. And effects or side effects, which I talked about a couple of minutes, none till date, obviously with the God's grace. In conclusion, I'll say we have come a long way from a diagnostic tool to therapeutics. SonoView is available, not a definitely today. Non-invasive evaluation of capillary integrity, that is endothelial function, is possible. Unique tool for assessment of myocardial perfusion. Portable, cost-effective, and that's approved indication today for LVO pacification. Hold promises a non-invasive method for detection and quantification of coronary artery disease. Indigenous modality for future indication for drug and gene delivery. Newer imaging modality is still being developed for myocardial contrast echo. That's a promising future. Thank you very much for your patience hearing.
I think I have a very quick comment. We do perfusion a little bit differently than many others. What we do is we go for low mechanical index. You have a normal mechanical index about 1.6 to the power of the echocardiographic machine. We drop it down to about 0.4 or 0.3 because at that level the contrast does not get destroyed. If you inject contrast and keep the power normal that you do for 2D echo, the contrast will actually break down very, very quickly and disappear. So we go for low mechanical index, and then while we're at the low mechanical index and we see perfusion in the myocardium also and in the cavity, we turn the power up to normal, to mechanical index 1.6. What that does is it destroys the contrast completely from the myocardium, does not destroy from the cavity because there's too much contrast in the cavity, destroys all the contrast, and then we see how fast it fills up. And when you turn the power on, you have a flash artifact, and that destroys the contrast. And then if there is no filling of any segment, that means that is not viable. That's fibrosis, dead. And if there is filling, immediate filling, that means the coronary artery supplying that particular segment has no stenosis. If it fills up slowly, that there is stenosis. The more slowly it fills up, the more severe the stenosis. That's how we evaluate myocardial perfusion. And we can do this at rest as well as with a stress agent, stress echocardiography like budobutamine, also exercise testing. And this technique actually works very well. Most of us practice that technique, which was originally developed actually in Germany in collaboration with our laboratory in Birmingham. And that seems to be the practical way of looking at perfusion. Thanks. Just a quick comment.
So we should practically close the combined session between the 3D echo and the atrial fibrillation. And shall you call on the VT storm management? Shall we go down?
Ladies and gentlemen, we'd like to thank the chairpersons for being kind enough to carry the session so far.